So I'm going to talk about hormones, and I am Joi Davis. I've been an OBGYN in Waukesha for 23 years, and the longer I do this, the less I know. So if you guys want, if I make you a little confused, it's probably because I think it's confusing, and you can read all sorts of stuff and talk to all sorts of people and get all sorts of different answers. So I'm going to try to give you my version. Hi. What is a hormone? So a hormone is basically a chemical messenger that the body makes that from inside. So inside the body, they're circulating, so they're called endocrine. So endo means in. So they're made in the endocrine glands, and they direct a lot of body functions. And they attach to target cells or target tissues, and then they tell those target tissues what proteins to make or what actions to do. The endocrine system, there's a lot of different systems. They're controlled by the pituitary and the hypothalamus. And there's the thyroid, the parathyroid, the thymus, the adrenals that are blue, the pancreas, and the ovaries are the testes. So the hormones that are made go back into the brain, and it sort of controls like a gas pedal how much the brain tells the gland to work. It feeds back. It says, "Okay, I'm working," and then the brain slows down. So they're really kind of all working together. So. A lot of medicine is just, a pulmonologist looks at the lungs and a gynecologist looks at the ovaries. And so a lot of it, the bigger I make my vision, the more confusing it gets to me on how all these things work. But I think there's three that I'm going to talk about, three of these glands, and it's the thyroid, the adrenals, and the ovaries. And I think they really are important for us, especially modern day, and how our stress is and what happens with our hormones as we age. But the adrenal and the ovarian hormones are made from cholesterol. So, we're taught that cholesterol is bad, but we actually need cholesterol to make these hormones. Progesterone is one of the female hormones that's early on in this cascade. Progesterone can be converted to cortisol, which is our stress hormone. Aldosterone is another adrenal hormone that controls like fluid and electrolyte metabolism. DHEA and testosterone are kind of the androgens, the male-like hormones, and then those are converted into estriol. But progesterone, if you just remember, this is real early in this cascade, and it's important for all of these other hormones. So again, I'm going to talk about the thyroid, the adrenals, and the ovaries, kind of as all three affect each other. And when one is off balance, it's like a three-legged stool. It can throw everything else off. And I didn't really look at this in this way until about a year ago. So the thyroid, our metabolism gland, basically, it controls almost every body system, our digestion, our energy level, our muscles, our nerves, everything is really controlled by the thyroid. It uses iodine, so that's really where iodine is important. About 150 micrograms. I know that a lot of salt is iodized, table salt, and years ago we started adding, the food industry put it into our table salt, so they're really, and I was taught there's really not anything, there is no iodine deficiency in our country. Unfortunately, the Heart Institute says don't eat salt. Everybody's going to sea salt, and I think I am picking up a lot more iodine deficiencies because we don't use as much salt. We're taught not to. So I think every time we tell people something is dangerous, we create something else, like the fish, don't eat fish, it's heavy metals. Now we have fatty acid deficiencies. And there's two main thyroid hormones, T4 and T3. That's how many iodine molecules are in them. 80% of our thyroid hormone in our body is T4, but the active form is T3. So actually 15% of the population may not be able to convert T4 into the active. And when we measure, or when we replace thyroid, in the regular medical world, we replace T4, which is levothyroxine, and a lot of women don't feel good on just T4, and we're really, in the medical world, don't look at T3 as much, but I think we're, a lot of people are starting to look at that more. Symptoms, fatigue, depression, weight gain, feeling cold, dry hair, dry skin, hair loss, a lot of muscle cramps, elevated cholesterol, memory loss. Those are all symptoms of hypothyroid. The adrenal gland produces four main hormones: the androgens, DHEA-S, and testosterone, glucocorticoids, the cortisol, which controls the sleep-wake cycle, suppresses inflammation, generates energy. It actually makes our liver produce glucose. It regulates our blood pressure. The mineral corticoids, or aldosterone, regulate our fluid and mineral excretion. And then the catecholamines, the adrenaline, norepinephrine, dopamine, all are produced in the adrenal gland. And the regular medical world looks at, is it okay? Is it too low, which is Addison's, or is it too high, which is Cushing's? And so we really only recognize too low and too high. We don't recognize that middle part where maybe it's just not quite right. And I think that a lot of this is stuff I didn't look at until recently with the adrenal. I think people want to feel optimal. They don't want to feel just okay. And some of the criticisms of looking at the adrenal imbalance or fatigue, adrenal fatigue, is don't put a diagnosis on patients if they don't really have one, because is it not, is it just not quite working okay? Let's not put a diagnosis, because pre-existing conditions were a problem for insurance companies, and we were really careful not to do that. So I think we don't always recognize this. And again, cholesterol, here's the mineral corticoids. There's progesterone right there. Here's the glucocorticoids. And then the sex hormone, the DHEA-S and testosterone. These are all, our adrenal gland needs testosterone. And if, let's say, someone's under a lot of stress, and back in caveman days, if a tiger came chasing a caveman, the cortisol would kick in, high stress, get some glucose, get your muscles, get alert, get fast, increase the heart rate, and run away. Well, now our adrenals don't recognize a tiger from a, job interview, from kids that need to be at soccer practice to across town to another thing. And so stress is different, and really much higher now. So, work, finances, home, school, excess exercise can be very stressful. Overcommitting, I think a lot of us do that. Physical injuries, bad nutrition. Dan can help us with the supplements. Are we putting stress on ourselves, just emotionally reacting to things differently? Poor sleep, death, can't avoid surgeries. A lot of people get run down after surgeries, chronic pain, social media, not being able to shut that off, or worrying about what is said. That's a lot of effects. So symptoms, is it adrenal fatigue? And I really struggled with this. Is this real? Is it not? Well, yeah. I mean, we always say don't have stress. Just deal with, learn to deal with stress. Well, it really does bad stuff to us. So, and I think this is an answer to it. And whereas not every, medical profession will call it this or recognize it, it's because it's either got to be way broke or just okay. And so that might be the discrepancy. But, it can cause digestive problems, fatigue, weakness, so kind of the same things that low thyroid cause. And balance, we don't want to treat something when somebody's doing bad, unhealthy things for themselves, eating, you want to correct the nutrition, you want to try to learn to deal or balance your life, and I think that it's easy to just say that, but to actually figure out or have somebody teach you how to do it is tough. So we'll go to the sex hormones. So here, I show this picture all the time. This is a menstrual cycle, so from onset of menses till we reach menopause, our ovary is making a follicle. The follicle is producing estrogen, which is the yellow here. The estrogen gets to a certain point, it triggers the pituitary and the hypothalamus to shoot off some LH, which tells the ovary to release the egg, okay? And that's really, so we do the FSH and LH kind of spike right in the middle. Egg is released. The ovary turns into a corpus luteum, the follicle turns into a corpus luteum in the ovary, and the corpus luteum produces progesterone. So you have to ovulate to produce progesterone, and then progesterone takes the lining, which estrogen, I kind of say it's like the fertilizer. So if your lining of your uterus was a lawn, and estrogen's the fertilizer, and then progesterone's like the lawnmower. So you want to, even it out, make it thick and plush. And so it's making it available for a fertilized egg if that occurs. If it doesn't occur, this corpus luteum only lasts for about 14 days, 12 to 14 days, and then it dies because there's not a pregnancy there to tell it to stay around, and then the progesterone abruptly drops off, and that's what makes the lining come out. So we have to ovulate, we have to produce progesterone, and then progesterone, if you remember, is sort of the precursor to a lot of the other things. So, when that's off, it kind of can throw off everything. So here again is the pink things are the things that the ovaries produce. The green is the adrenal, and then the blue is what the testes, the male hormones. So we have a little bit of testosterone as well, and it's from our adrenals. And they really you want them to be balanced. So if you're demanding a lot of cortisol because you're under constant stress and you're go, you're gonna divert some of, your body's got to find it from somewhere, so it's going to divert some of the other functions to make, to handle. And then if you don't ovulate, it kind of throws off everything. And so I really think the three together need to be looked at. As we age, we don't ovulate as well. Things change, so if we look right before puberty, things are just starting to rise, and then it's kind of erratic the first few years of our period. Then we have, while we're menstruating and before it starts to go crazy again toward the end. So right at the beginning, right at the end, it's can be real erratic. But here's where we have our power. I think progesterone is like a very important hormone, and my experience was I had surgical menopause, and when my ovaries came out 5 days later, I was vomiting, I was sick, I was exhausted, I couldn't function. I started having crazy hot flashes. I tried every single prescription estrogen, doubled and tripled them, and felt like crap. A year and a half ago, came to a seminar these guys were giving. I'm like, all right, I've tried everything. If you guys think you can fix me, I had hormone testing done. They put me on some things, and I swear to God, in a couple weeks, I felt like a whole new person again. And I wasn't doing progesterone because I had a hysterectomy. We're taught not to use progesterone if you have a hysterectomy because you're not at risk of uterine cancer. And it was really progesterone that I needed. And I think it was my, kind of stressful life. I was, just really very much off balance with the whole adrenal stuff. So there's also toward here more estrogen than progesterone, and that estrogen dominance, it's called, it can be a problem, and that's where, when we see breast cancer. So, all sorts of stuff. Most people I see complain about this in their 40s. You start to lose your progesterone effect around 35 into the 40s. And this is all the symptoms that we try to treat. So bioidentical hormones. I think Suzanne Summers was probably the first one and in the medical world we're like, oh yeah, what does a movie star know about this? She doesn't know what she's talking about. She's not a physician. But so it's a little bit of a marketing thing, but what it means is hormones that are exactly like what is made in the body. So our bodies are used to it. Our cells respond to it. There's receptors for it. So it's basically natural. Natural products can't be patented. So the pharmaceutical industry they have a few products, but they patent the oil that progesterone is in. They don't patent the progesterone. Or estradiol patch is bioidentical. They have patented the glue that they use for the patch, but they can't really patent. So they're not going to study it. They're not going to spend a lot of money on it because they're not going to make a lot of money. So I think that's part of the stuff, because I do think a lot of the advice that we are reading, when I look critically at it, they are linked. Every author I've read is linked to a pharmaceutical company. So, they got to be a little biased, and I think that they are. But bioidentical hormones also means restoring hormones to a balanced physiologic level of like youth, so like 25 to 35, in that range. Here's another portrayal of the, progesterone, estrogen kind of balance, then progesterone runs out first, and we get this crazy estrogen stuff right after menopause, and then things just kind of drop as well. And there's a lot of stuff that goes on in our body. So menopause, we define it as the end of the last period. So, but you have to be 12 months before we can say that was your last period. So you have to go that doesn't mean we don't treat you for 12 months, but it just means that we don't really know. So people that have had a hysterectomy, people that have had ablation, we don't always know when their actual menopause is, but the perimenopause, or the time it can be the onset of symptoms till a while after. The range is about 50% of people have stopped their periods by 51 and a half. The range is probably 45 to 55. I have a handful of people that are up closer, that get to maybe 58. I don't think I have anyone over 58 that was having periods anymore. Transition can happen for even up to 10 years before, and it can be pretty dramatic for some people. And I think it's the crazier life you have, the harder it is. Obviously smokers, it would happen earlier. So what happens to all our hormones? The catecholamines go up, glucocorticoids go up. So this is the adrenaline and stuff. I think it's just the adrenal just, come on, keep going, try it. Just keep, testosterone, estrogen, androgens all go. And then interleukin is, that was just on this slide, but that's more of a inflammation thing. So, you know, things that we don't want go up, things that we want go down after age 50. I put in here, and this has been my struggle, American College of OBGYN, the American Society of Reproductive Medicine. Those are the organizations that make statements that, you know, the medical world, you know, making recommendations. And they say evidence is lacking to support superiority claims of compounded bioidentical hormones over conventional menopausal hormone therapy. But customized compounded hormones pose additional risks, but that's because they say they have variable purity and potency and lack efficacy and safety data. They studied this by going on the internet, ordering 25 different compounded hormones. Some had no hormone in it, and some didn't have what they said. But you know, I think if you order anything over the internet, you'll get 25 different products. And so I think it's important to have a pharmacy like MD Custom that's PCAB accredited, and they have those standards and they meet those standards and they do what they're saying. So they're saying, well, 20, you know, what we ordered, so they're all bad. And I think that that's not really fair. And then variable bioavailability and bioactivity, both overdose and underdose are possible, and that's based on their testing of what they said. But I think, you know, here they use hormone levels, they test, and I think they do a great job here, and they certainly do a great job for me. Conventional hormone therapy, so this is the pharmaceuticals, is preferred over compounded hormone given the available data. Well, the data is all generated from the pharmaceutical industry. So they're not publishing the stuff, and I'm just been scouring that literature and going, where have I been for 20 years? You know, not really looking at the big picture. So evidence is inadequate to support increased efficacy or safety for individualized hormone regimens based on saliva, serum, or urine testing. But again, they're testing different, you know, they're testing it wrong. They might do a blood test for an oral medication or a topical medication. They're not really understanding what they're testing, and I think it's been hard for me to kind of sort through all this, but basically I don't really follow what they say anymore, because that's not what patients want when I really open my eyes to it. The reason, so in 2002, the Women's Health Initiative came out, and this was a big study that made hormone replacement taboo. It was launched in '93. They closed it in 2002, I think. They had almost 162,000 women from age 50 to 79. They just took, and the average age I think was around 63. So they started them on Premarin and PremPro, which is not natural or bioidentical. And this study showed 29% increase in heart disease. So if we took 10,000 women, 37 of them would have heart disease versus 30 that didn't use hormones at all. So 7 more. 41% increase in strokes, 26% increase in breast cancer, 37% decrease in colon cancer, and 34% decrease in hip fracture. So it helped colon cancer, it helped osteoporosis, but it caused heart disease, stroke, and cancer, breast cancer. So what does that mean? 7 more women would have heart attacks out of 10,000 if we put them on Premarin. 8 more women would have strokes. 8 more women would have breast cancer. 18 more women would have blood clots. We'd have 6 less colon cancers, 5 less fractures, and fewer fractures in any bone. So a lot of women after 2003 just stopped hormones, and then every hormone was bad, which really they just tested Premarin. So really Premarin is bad. Here's all the pharmaceuticals, Premarin. There's micronized estradiol. There's 17-beta, the transdermal. There's esterified estrogen, which is not bioidentical. Really, the only one that's bioidentical is right there. Micronized is not, right? Or is it? No, estrase is. Estropipate is not. And then the synthetic conjugate, they actually made synthetic Premarin because Premarin was so popular. So, the difference between the pharmaceutical and bioidentical is the bioidentical hormone balance is achieving physiologic, not pharmaceutical levels. So that means you're not deficient, but you're not excessive either. It takes into account, you have to do endocrine, lifestyle, and environmental balance. So that is not easy, and it's not fast, because it takes a good couple of months to get there, because you go up slowly. If you go too much, the brain makes adjustments, based on whatever's going on. So if you have too much, your brain's going to shut down everything else and go, okay, well, I don't have to do anything, because, that's how birth control pills work, because we go high to shut it down so people don't ovulate. We want to address the symptoms, but we also want to provide protective benefits to the heart and brain, nervous system, bones, muscle, skin, and the vaginal tissues. So, and I think that with bioidentical lower doses and starting earlier in the 50s and not in the 60s is better for women and actually healthy. So it's just now we're getting back to women are starting to use it, but a lot of women suffered for a long time after the Women's Health Initiative. So conventional hormones is really estrogen dominance, because and what happens is the cells have receptors that attach, the hormones attach to get into the cells. And if there's a lot, so I'll compare it to like a Packer stadium. Let's say we have a high school stadium and there's going to be a Packer game there. There's going to be a lot of people coming and they don't know where to go. So you build this big stadium, and now all of a sudden you have a lot of people in a big stadium, and the stadium's used to it, but then all of a sudden you lower the volume, and you have this big stadium not knowing what to do. So the cells do that with the receptors. When you take a pill by mouth, it passes through the liver and it degrades it, and it can produce metabolites out of what you're taking by mouth, which is why I'm starting to favor topical. And then the higher it is, your brain starts to need more. It's almost, like any kind of resistant, drug, morphine, you need more and more and more because the levels are so high. And then the receptors almost get insensitive to when it's too high. And it's hard to shift people back physiologic once they're, it's very hard for me to convert my Premarin patients to bioidentical. So our body's response is we decrease our own hormones, we increase the binding globulin, and that makes the hormones inactive while it's carrying it. So really only the free hormone is the one that works. And then we downregulate our receptors, and that's also called tolerance. And this could occur over months to a year or so. when we take oral hormones, bioidentical or not, our stomach acid degrades it. It goes into the liver metabolizes it. It's called first pass metabolism. It might be released out of the stomach slowly. Absorption may vary depending on how functional our gut is. It produces metabolites. Who knows what those metabolites are doing? We're certainly not measuring metabolites. Estradiol is actually converted to estrone, which is one of the 3 estrogens that are bioidentical. And estrone is believed to maybe increase cancer. When it goes through the liver, it raises the clotting factors. It raises the triglycerides. It affects the liver, the lipids in a negative way, which probably increases strokes. It raises the binding globulins, like I said. It increases insulin resistance, which is diabetes. And then prometrium has to be oil-filled to be absorbed. It only lasts for about 6 hours, and about 90% of it is degraded. So you have to go real high. You know, our prometrium, progesterone, the pharmaceutical bioidentical equivalent is 200 milligrams, and we can use topicals that are around 20 milligrams because of it's not degraded. So this is kind of what happens. It goes into the stomach, through the liver, 90% is metabolized, and then it goes into the circulation through the heart. If you take it by nasal or buccal, dissolve it on your mouth, or topical, which is what I favor, it goes directly into the bloodstream. You don't have to, bypass the liver and affect all the liver enzymes. So I've really started to use a lot more topical. It's lipophilic, which means it goes into the fat layer, and it sits there. It's naturally depot, so it's a natural storage area that can be released over time, and then the carrier proteins pick it up, and they can also store it for later use, so you kind of have this longer duration. The target is the lipophilic tissues, not the bloodstream. So if you're measuring blood levels of hormones, you're not really measuring where you want it to affect. You're measuring what's in the carrier protein. You're not measuring the active hormone. And then absorption is through the skin is, affected by a lot of things, and that's what really they do here is determine how much to give at one time. How the accuracy of each dosing is, and they've really, I went to a whole day talk on Monica showing us why they do what they do and how they figure this and how they calculate this. And I don't know that every compounding pharmacy, especially not the CCAB ones, will do this. What base they mix the hormone in, and then what's the hormone status of the patient. So is testing good? I used to think that I could just say, well, what are your symptoms? And I'll just treat what your symptoms are. I think many times we can do this, but sometimes different, like I showed you, different hormone symptoms overlap with other ones. So what I think might be happening could be something totally different. And one of the lines I've heard is test, don't guess. And I've been guessing, 20 years. Symptoms could be caused or aggravated by other hormone imbalances or even nutritional deficiencies. And then sometimes if you have too much hormone, it may seem like you don't have enough based on symptoms. And then all the hormones interfere with each other, environmental stress levels, lifestyle factors, all, you really want to look at that whole picture. So how do we test? If we test the urine, that's really the metabolites of everything that the body doesn't want and is excreting. So you can measure metabolites, sometimes and see how much excess you're giving off, but that doesn't necessarily say what what is happening in the body at the time. Saliva has been shown to correlate with tissue levels, so it's the free hormone. It's really the way that they are looking at the adrenal rhythm of the body in usually 4 to 6 different measures throughout the day. You can get pretty good information, although during any given cycle, if someone's menstruating, you want to do it during a certain time of the cycle to pick up you're not going to pick up progesterone on day 5. If you're taking it under your tongue and you're taking your saliva, you're going to have a higher level of hormones. So I think when we're testing, we need to know that. It doesn't measure things like the thyroid, the binding globulins, because they're too big to get into the saliva. In the blood, there can be wide levels, and I've always said this is, it doesn't help me because you're measuring the bound and the unbound. You don't know what the binding globulins are. Androgen, like the variation in testosterone levels for females can be like 5 to 150 or so, the range is too big, so I don't really use blood that much unless I'm looking for too high or too low. Capillary is a little bit like saliva, but we have to look at if you're taking hormones, how you're taking them, what time you last took them, how many doses you've had. Do it when the progesterone is at its peak, if someone's having menstrual cycles. And then if you test the cortisol, you want to kind of do it on an average stress. You don't want to see when it's too high or too low. You want to kind of see what your average is. So I just gave a few examples of why testing might be wanted. So if we take hair loss, a lot of people come, my hair's falling out, test my hormones. So is it high cortisol? Is it low estrogen? Is it high or low testosterone? Is it the DHEAS? Is it the thyroid, progesterone, or is it something else? You're pulling on your hair or whatever. Nutrition is bad. So I think sometimes the hormones would differentiate from that. Mental fog could be all of these. A lot of us get mental fog as we get tired, menopausal. Weight gain, these are all the things that can cause weight gain, those are probably the 3 most common complaints that I see that I might want to try something, but then test for it. The goal is to do the lowest dose for the shortest amount of time. And really, if we start low, be patient, and go slow with our dose adjustments, the body reacts a little bit better. And then you want to kind of free up your receptors and give them a break or take a little drug holiday, either on a weekly or monthly basis. So maybe we might give it if you're not menstruating, we might have you off one or 2 days a week. If you're monthly, if you're having cycles, maybe a week out of the month, that we kind of vary things. As far as the Women's Health Initiative and the newer findings, if we're using oral pharmaceutical hormones, they're probably okay for the first 10 years right after menopause, as opposed to, the women in the Women's Health Initiative were really average age of 60s. So they were a different breed. But if, I'm really starting to go for more compounded topical things because there's not a lot of pharmaceutical things that suit what my criteria is, and then we want to make sure they're PCAB accredited and do a good job and have a nice product. So Debbie Tietzen, stand up, and Debbie's a nurse midwife, nurse practitioner with tons of experience. How many years? 20?
I've been doing women's health since 1994.
Yeah, so between her and I, we have a lot of varied experience. But I'm over at the Wisconsin Vein and Medi Spa. My clinic is called Age Defy, and we we are working with MD Custom and ZRT Lab to do hormone balancing for women. So we'll really, try to look at your history, lifestyle, all of that. Probably check hormone levels. I don't know that I always have to do it, but I think it is helpful. And I like that we can collaborate with, so the ZRT has, 35 years of experience or more. They've got a really nice computer program where they take all your symptoms and your hormones and it spits out an algorithm of, what they think. And then Monica here and some of the other pharmacists, Monica really looks through it after they puts her little blessing. So you got a lab person, a pharmacist, and then after Monica looks at it, I look at it, and look at more of the medical health history and talk directly with the patients, and then we map out a hormone plan and prescription for you. So I like working as a team. I like that there's, 3 brains, because I don't think I know everything. I learn a lot from them. They learn some stuff from me. I think the ZRT is a great lab, and so that's what we're doing. So.